Greetings and welcome everyone to the Association of Academic Health Centers International Southeast Asia Regional Roundtable. This roundtable is in conjunction with AAHCI's 2021 annual meeting, themed Leveraging Lessons of the Pandemic to Accelerate Evolution of the Academic Health Center, and is one of many platforms for leaders in the region to connect and share their programs, initiatives, and experiences. Please don't forget to register for our event next week. We have a great lineup of sessions from September 27th to October 1st, and the link will be inserted in the chat box. Without further ado, I am pleased to introduce Dean Ari Sayam, Dean of Faculty of Medicine of Universitas Indonesia and Regional Ambassador of AAHCI Southeast Asia Regional Office. Dean Ari, the floor is yours.
Okay, thank you, Habiba. Professor Ben Howden, Professor David Mulyono, distinguished members of Southeast Asia, ladies and gentlemen, good morning. So I would like to express my warmest welcome to all of you today in joining this discussions on COVID-19 challenges and lessons learned. As some of you may know that the Southeast Asia region has become emerging hotspot for COVID-19. So in today's discussion, we will look closely at innovative ways academic health centers are responding to pandemics through genomic sequencing, to identify SARS-CoV-2. The global propagations of SARS-CoV-2 and the detections of large number of variants, some of which have replaced the original clade to become dominant, underscores and the fact that the virus is actively exploring its evolutionary space. We know that the genomic sequencing has played an important role to monitor how the virus changes over time into new variants, predict how large the pandemic might be from the virus mutation potential, prevent and mitigate the spread through vaccine distributions in the region. We hope that you will contribute to this discussion and gain a better understanding of which variants are circulating in our regions, how quickly variants emerge, and which variants are the most important to characterize and track in terms of health, as well as how it might impact health overall. I hope that we will try to see how we can overcome this problem together. Before we begin, I would like to welcome our newest members of AAHCI from Indonesia, from North Sumatra University, and also from Islamic University of Sarif Hidayatullah, Jakarta. Welcome and thank you for joining us. We look forward to working with you. It is now my honor to turn over to our guest and facilitator for today, Professor David Mulyono, who is the Deputy Director of Eijkman Institute in Translational Research. Thank you very much for Professor David for your kind contribution in our roundtable discussion today. Please, Professor David, time is yours.
Thank you. Good morning. My name is David Mulyono. First of all, I would like to extend my welcome and gratitude. The first is to Professor Howden and our Professor Ari Fahrial Syam and all the members and all the participants of this meeting. I would like to introduce Professor Benjamin Howden, who is the Director of the Microbiological Diagnostic Unit Public Health Laboratory at the Doherty Institute, Australia. I'm proud to introduce him because he is an established leader in public health and pathogen genomics research, and his laboratory has pioneered statewide and national coordination and implementation of microbial genomics into public health practices, including in response to the COVID-19 pandemics. Now, it's a great opportunity to invite Professor Howden. The time is yours.
Thank you very much for the introduction. It's a real pleasure to be here. I will just share my screen and hopefully you can see that. Thank you. So hopefully you can hear me and see the screen, and thank you again for the invitation to speak on this really interesting and important topic. And it was great to hear the introduction about the importance of genomics and understanding viral evolution and variants in our response to the pandemic. So I will give a few minutes just discussing some of the lessons learned in Australia and some of our partners in the region and the challenges in using genomic technologies for COVID-19. I really do come from the public health research interface. So what I'll do is give a brief introduction to the Doherty Institute and my laboratory, the MDU PHL, a couple of slides on genomics implementation in Australia and how this allowed us to transition to quickly addressing the COVID-19 pandemic, and some summary of lessons learned, and then just a slide on the Illumina University of Melbourne partnership, which has been established, which is really supporting genomic research and initiatives across human and pathogen genomics in future. So the Doherty Institute is based in Melbourne, Australia. It's a reasonably new institute that's brought together University of Melbourne partners, particularly the Department of Microbiology and Immunology, with colleagues who work in public health laboratories and in hospital infectious diseases medicine. And here you can just see the key pillars of activity in the Institute: immunology, viral diseases, antimicrobial resistance, host pathogen interactions. And there are a number of key cross-cutting disciplines, including public health, epidemiology, and genomics, which are obviously very relevant to what we're discussing today. So the laboratory that I am director of is called the Microbiological Diagnostic Unit Public Health Laboratory, and it's really a public health lab that's transitioned to specialising in genomic public health. So we've been working on this program for the last 7 years or so, and really changing the way we work in the laboratory at the public health lab interface, underpinned by research activities in this area. So we're responsible for surveillance, diagnostics and outbreak response across a number of diseases and pathogens, including addressing COVID-19. In response to the COVID-19 pandemic in our region, we've established a regional genomics section of our laboratory because of the clear need and appetite for access to the technology in the region and access to the expertise to understand and interpret the data. One of the key things we've done in Australia and New Zealand, and I think this is a really important lesson on how to implement genomics across jurisdictions or across countries, is to establish the Communicable Diseases Genomics Network, which is a network of public health laboratories that work together collaboratively to implement and understand the use of pathogen genomics for public health. And that's been quite successful in Australia and New Zealand. And then the other thing, which we've been working on for a few years, but has really been pushed forward quite quickly because of COVID-19, is a national platform for private and secure sharing of genomic data for public health. And so this is data generated by public health laboratories and shared between public health laboratories for nationally consistent and real-time integrated analysis. And that's been a really important part of the response in Australia, which I'll talk a little bit more about. So one thing I will say is that implementing genomics into public health is quite a long process, taking it out of the research laboratory and transition it into a tool that is both for research and for public health action. And this is just as a summary of some of the activities that have happened in Australia over the last 7 to 10 years. I've grayed out most of them. I won't go through all of them. I guess what I would like to highlight is that it's about 7 years ago where the Public Health Lab started to undertake research activities using genomics to demonstrate the value of the technology for our public health colleagues and Department of Health funders. And through that type of activity, we were then able to inform government of the value of pathogen genomics as a tool for public health, and also the importance of data sharing, so finding strategies for integrating and sharing data. And then in 2016, we formed that national network that worked together and has worked collaboratively over the last 5 years to bring data together at the Public Health Lab interface. And ultimately, this has led to a national microbial genomics framework being developed and released, which is a very important piece of work in Australia to drive the direction of microbial genomics over coming years. And in response to the COVID-19 pandemic, the platform we'd been working on and developing for a few years was fast-tracked and is now considered the national platform for integration of genomic data in Australia, called AUStracker. Some of the things we've learned about taking this technology to the public health interface is some really being aware of all of the aspects of this, which includes, how we get quick access to samples that need to be sequenced, how we select the right samples for sequencing, how we make sure that they're appropriately shipped to the laboratory and undergo high quality sequencing, and then bringing together the key personnel in the laboratory that need to work on this. That is the medical microbiologists that oversee the processes and the quality assurance, the bioinformaticians who analyse the data and work out systems for analysis, quality assurance and data sharing, and then the new and emerging specialty of genomic epidemiology. And this team of people is critical to using this data at the public health interface, and these are people who are trained in epidemiology but also understand genomics, and they can work to bring those two key pieces of data together, the epidemiology data and the bioinformatics analysis. And this leads to effective reporting to key stakeholders, particularly public health, but obviously also diagnostic labs and hospitals in certain circumstances. The other key thing we've learned is about the really critical nature of data governance and appropriate approaches for data sharing. So these things cannot be underestimated, the importance of ensuring that the laboratories feel confident in sharing their data, and the public health units also have confidence in sharing the epidemiological data in real time. So just to focus a little bit more on specific COVID-19 activities, one of the key things that happened was some funding from our Medical Research Future Fund, which is our translational medical funding body. And this funding went to primarily laboratories that were part of this national network, the CDGN. And this was a translational genomics program to really try and coordinate COVID genomics activities around the country, and bringing the data to the public health interface on understanding what's emerging and how to respond to it, and some other key types of activities which you can see there. And the main thing here was that AUStracker underpinned this activity, and so the deployment of this national platform for genomic data sharing and epidemiological data integration was a really key part of this project, which started quite early last year and is still going. So just two slides on a bit more detail about how we've used this project and these platforms to inform what we've done in Australia. This is a summary of genomic data from my jurisdiction of Victoria over the first 12 months of the pandemic. I'm not going to go through the detail, but what the figure shows is all of the genomic clusters that we've detected over that time, showing that early on we had a lot of different genomic clusters from return travellers coming from overseas. They were all eradicated through public health interventions, such as stay-at-home orders and effective hotel quarantine. But then in the later period, you can see this very dark blue big cluster here, which genomically and epidemiologically was confirmed to be an outbreak, leading to a huge second wave of infections in our state, which is all due to a single hotel quarantine breach. And so this information was very powerful because it allowed our public health units to understand the source of this new outbreak and led to a whole inquiry that changed the whole process for quarantine activities in Australia. The other thing that we did was share this data using AUStracker, the national platform, and quite quickly we could see that this clonal outbreak was spreading to multiple other jurisdictions. And this was information that led to internal border closures within Australia. So you can see the power of that information there. Clearly, there's a lot of interest in variants of concern, and one of the key activities of the AUStracker platform and the national program has been systematic detection and reporting of variants of concern at the national and state level. And so we now have a weekly AUStracker variant of concern report, which updates on numbers and jurisdictions represented with new and emerging variants. And this has led to variant-specific guidance on how to control the spread of the disease, particularly around quarantine approaches for individuals who are infected with a variant of concern. So while all of those activities have been going on at the national level, we have also been providing some support in the Southeast Asian region. I thought it's just worth highlighting some of the lessons we've learned from this activity. As I said, we established a reference lab for COVID-19 genomics, which is working in the region. And really, key activities have been to support strategic approaches for genomics implementation in a couple of partner countries, and also to act as a rapid referral laboratory, including sequencing and analysis and reporting. And it's really been quite clear that it's important to bring in public health labs and ministries of health in these partner countries, because the use of the data is much greater in that setting where these activities are supported through Ministry of Health involvement. And as I mentioned earlier, very clear protocols around what is being referred, what needs to be sequenced and why, and very strong agreements on data governance are important. And sampling guidelines has been critical, and these are still evolving in our region and globally, I think, around the appropriate sampling guidelines to make sure that we have geographic and temporal representation of cases that are sequenced, and that we're looking for potential emergence of new variants over time. And then capacity building is a key activity that can occur as part of these relationships, and even if it's not generating genomic data in laboratories, just that ability to understand the reporting, the linking of epidemiological data to the genomic data, and the integration with public health surveillance teams has been a really valuable capacity building activity as part of these types of activities. And what this is just an example on the right, and I won't go through the detail, but each of the colours of these dots are different countries that we've been working with, and you can see that some of the key lineages, including the Delta variant here, and you know, for a few of these countries that variant has not been detected, but you can see the emergence of it in earlier this year in one country in particular, which we were partnering with. And so that information is very important for those countries to understand the emergence of those variants and changes in public health responses. So what then are some of the challenges and lessons we've learned in Australia and with some of our regional partnerships on SARS-CoV-2 genomics? Achieving national consistency is really important because it allows the information that has been shared with national decision-making bodies to be consistent and reproducible, but that takes quite a lot of work to do that, and integrating the data and ensuring consistent reporting approaches is critical. The real-time sharing of data, whether that be genomic data, epidemiological data, or both of them together, is really important if you want to bring this technology out of the research lab into the public health environment. But there's a lot of work to do depending on the context in which you work around ensuring that that's possible, and also making sure that the systems are interoperable. There's a huge need for expert bioinformaticians and genomic epidemiologists in Australia and in our region. That we're really short on these types of workforce, and particularly those that can work at the public health interface. And there's a real disconnect between demand and capacity at the moment. And finally, I think sampling strategies are really critical, making sure that we over time develop clear, sensible and achievable sampling strategies that are going to allow us to accurately detect emerging threats as they come. Now, some of the key lessons learned, the COVID-19 pandemic has really demonstrated the critical value of pathogen genomics for surveillance and response, particularly at the public health interface. And I think we need to grasp this opportunity to deploy the technology more broadly in our region. Some of the things we need to do to optimise it for public health, as I've already mentioned, sample collection and referral, good governance and operational agreements, building those relationships between research and public health so that integration is almost seamless for this activity, and looking at how we get data integration occurring effectively, as well as connecting with decision makers so that they can see the value of the technology and support and sustain the activity over time. We've also found that it requires both a grassroots and a top-down approach. So either by itself doesn't seem to work. You really need that grassroots integration, but top-down support. And yeah, the bottom thing is essentially saying the same thing. So just 2 slides now on the Illumina University of Melbourne partnership. I think technology is obviously key for genomic activities that we're trying to deploy either in pathogen genomics or human genomics. The University of Melbourne is fortunate to have signed up to a partnership with Illumina and the Victorian government to establish a Illumina University of Melbourne Genomics Hub. And this hub is really trying to be at the forefront of genomics by nurturing the workforce and accelerating research, enabling core platform developments such as clinical genomics, bioinformatics, and health economics. And I haven't alluded to this, but I think we really have to understand good studies on the implementation and cost effectiveness of genomics going forward. And it's funding flagship projects, and you can see 2 examples here. One is the ID Predict, which is a genomics platform for COVID-19 patients, and another is a cancer diagnostic genomics project, and there will be other flagship projects funded in future. The partnership has been really important because it helps with, particularly our national funding body, the MRFF, likes to see industry partnerships on some of these projects. And this is just an example of some of the projects from the University of Melbourne that have been funded in partnership with Illumina over the last year or so. And the one I haven't listed the COVID-19 one there, but there is another large Australian pathogen genomics program which we're leading out of the University of Melbourne, which I'll just talk about for one slide. So this is my last slide, just to talk about what the future may hold. We've learned a lot about the value of pathogen genomics for public health through the COVID-19 pandemic. We were already ready to go because we knew that it was a good and important and valuable technology, but it's really been thrust into the limelight. And the Australian Pathogen Genomics Program is building on that activity. It's actually a program that includes every public health lab in Australia, as well as every public health unit and a number of academic organisations, and really trying to translate pathogen genomics into public health more broadly, not just for COVID-19, but a range of other pathogens that you can see listed at the bottom there. And another key example of where this technology is important is antimicrobial resistance, another pandemic which is ongoing in the background. And so while we're looking at implementation and integration, we're also closely evaluating the utility and cost effectiveness of these public health responses over time. So thank you, I'll finish there. Be very happy to take any questions.
Thank you very much, Professor Bowden, especially for your comprehensive lecture and informing us the spectrum of your activities and your contribution, especially for the genomics. And additionally, I appreciate that there is also activity on capacity building for this region. Now we have an opportunity also to listen what our members have done, and there will be 9, I hope that 9 presentations from our members in the following order. The first is from Erlangga University.
Apologies, Professor Muljono. Perhaps
yes,
before we begin with the member roundtable, maybe we can take this time to ask Professor Howden any questions following his presentation. So if anyone has any questions, if you want to raise your hand, you're welcome to go ahead and speak or insert your question in the chat box.
Thank you. So yes, especially for the Professor Bowden's presentation. Would you please any questions from the audience? Please feel free to ask questions or to give comments, or use the chat box at the bottom of the screen.
Boleh saya, can I?
Yes, please.
Can I ask question, David? Thank you very much. Good morning, Ben. And then it's a really great presentation there. And then I would like to ask questions about the concerns about the genomic and also the gene editing, because our university, as we are trying to approach the similar way, the similar pathway to develop the gene editing. However, one of the issues is, of course, the instruments, the analysis itself, and also the sample. With respect to the mutation that is currently happening, including the Delta version and also the Mu version, the variant of the COVID-19, how it will be affecting the prospect of the research in the genomic and also the gene editing in the future. That's probably our concern at this moment. Thank you very much.
Yes, thank you for the
much.
question. Look, I don't have a lot of experience
Yes.
in gene editing. I think we know that pathogens will continue to evolve, and so what we have to do is just continue to make sure we're sampling the genomic or the cases in a systematic way so that we understand the emerging mutations over time. And I think some of the steps in that are ensuring that we have access to the technology and ability to undertake the sequencing in countries around the world, that this is done in a systematic way, and also that the data is shared in a way that academics such as yourself and others can see what is happening in near to real time. And so I didn't talk about international databases where this data is shared, but there's close to 3 million COVID-19 sequences being shared through GISAID, which is an international database for sharing of sequence data. And so I think this is an example of the research and scientific community as well as the public health laboratories coming together to generate and share information that is incredibly important to address questions that you're asking. Yes.
Yes, I see a raised hand, Dr. Teguh Haryo. Please, Dr. Teguh Haryo, time is yours.
Thank you, Professor Howden. I'd like to introduce myself first. I'm Teguh. I'm from Malaysia. I'm in the University Perdana in Kuala Lumpur. That's very interesting listening to your talk just now. I think by now we would have recognized that data sharing is one which is very important, very urgent to do, yet is the part which is very challenging for many of us to do that. In your experience, what do you think is the hurdles, the problems in terms of data sharing? Like for this, now we do have a lot of platforms for data sharing in terms of the genomic data, but that in itself, I don't think it's enough. We do need a lot of more data to be shared among our members. And how do you think we can do more with this? Yeah, that's my concern. Thank you.
Well, thank you. Yes, nice to meet you. And it is a critical question. And actually, the data sharing is not just at the global level; it's at the country level, it's at the jurisdictional level, and actually, it's at the laboratory level between the laboratory and the public health unit. All of those levels have complexity in how we use and share each other's data. And so, just to address a couple of your things that you asked, one is that just sharing the genomic data alone is useful, but not ultimately what we need. It has to be more than that. And we want to be able to integrate key metadata that really value adds to the genomic data. Things like where the case was diagnosed, when the case was diagnosed, what risk factors they may have they been vaccinated or not. All of these things are very helpful in interrogating that genomic data. But it is complex, and because there's a lot of uncertainty about data ownership, but also about data security for individuals. Remember, we're taking this data from an individual who's been infected with a virus. And so personally, I think it's about establishing those relationships and putting good agreements in place. And what we've done in Australia, and I'm not saying this is the same for everywhere, but we have separated research from public health service a bit so that we share data for public health use. But if we want to do a research project on that data, we need other agreements for everyone who's contributed to agree to use that data for a research project. So I think trying to separate those two a little bit is important. and then having very clear governance around that you still own your data. Even if you're sharing it on the platform, it's still owned by the laboratory that generated it, and the other labs can see it, and the data can be analysed and reported, but you can't reuse it for other purposes without approval. So I think things like that, and each country and each region is going to have different complexities, but it's absolutely the way forward, and we should be trying to do our best to make this happen.
Thank you.
Thank you, Professor Bowden. After this, we will proceed with the brief summary presentations, but there are several questions in the chat box. Three. Yes, I think you can also read this. Yeah, there are 3 questions.
Yes, I'll just have a look at the chat box. So just a question about the current collaborations. I think this is still an emerging area. So we have collaborations which have been established through work on antimicrobial resistance in a number of countries in the region, including Nepal and Bhutan and Bangladesh, as well as Pacific Island countries, PNG, Fiji, and Timor-Leste. And so the data for COVID at the moment is primarily related to PNG, Fiji, Timor, and some other Pacific Island countries. But our relationships and partnerships are quite broad. I'm from the Doherty Institute in my lab, and so we're keen to partner, because I think in the region and our region, we need, as the previous question alluded to, we need to find good ways to share this information in an appropriate way, so that our whole region understands what the emerging threats are. And I think there's a lot of work to do that. But I guess that picture I showed was just an example of what we could do through appropriate agreements around collating and sharing information for the Asia Pacific region. But that's to answer those 2 questions. The question about strategies for reducing the translational timeline. I think what we're doing is bringing the sequencing to the public health labs. So we need the academic input to help us understand some of that data, but you also need to take the technology to the public health labs and allow them to develop the expertise to do the sequencing and do the reporting at a systematic level, and then bring in academia to value add to that public health activity. That's the model I think we should be looking at.
Thank you very much. So I think you've answered all questions in the chat box. So may I continue with the presentations of the members? We have here 9 speakers who will present with the following order. The first is from Airlangga University, then Duke NUS Medical School, Universitas Gadjah Mada, then National University of Singapore, Universitas Indonesia, University of Malaya, North Sumatra University, UIN Syarif Hidayatullah Jakarta, and finally University of the Philippines. So we would start with the presentations, and first I would invite a presentation from Airlangga University.
Thank you very much. Bismillahirrahmanirrahim. Thank you very much, Prof. David Mulyono, for your warm introductions. Good morning, ladies and gentlemen. Allow me to introduce myself. I'm Andi Hermansyah from the Academic Health System of Universitas Airlangga. I'm the second secretary of the health system, and I'm speaking on behalf of the organizing committee and also particularly the head of the academic health systems. Within the next 5 minutes, let me explain about our achievement and also the progress in handling the COVID-19 infection led by the University of Airlangga and also the academic health systems. My title is about the innovation of Universitas Airlangga during the COVID-19 pandemic. We consider it an orchestra of collective mutual interests. As Ben said, that it needs involvement of many stakeholders, including those who are really concerned in health, and then academic health system in the Universitas Airlangga is one responsible think tank organization which should lead this change and also the innovation. Now, our outline of our presentation outline will cover two main aspects. The first is reporting our current innovation and also what is the next big thing in our research and development. So these are some of the innovation that we have already produced, whether it is in the trial concept or prototype or already implemented. In your life, you can see that there are some services built to achieve or to cover the remote and rural island of Indonesia. We have so-called the Marco 2019 expeditions, which is focusing on the Madura Island, close to our university, but it is still unreachable. And then we have our university floating hospital to what is called to travel around the islands within the Madura Islands. And then we also with Universitas Gadjah Mada develop a rapid diagnostic kit test. And another achievement that we have is producing a COVID-19 medicines in collaboration with the military and also other institutions in Indonesia. This is called the Kombipek Yudakov. It's a combination of several medicines in order to treat the patients with COVID-19. We also developed the what's so-called the portable negative isolation room, which enable the treatment and also enable the care of patients excludes from the hospital setting in the left side. And also in the Universitas Airlangga is part of the vaccine development, is part of the team who are responsible for vaccine development in Indonesia. At this moment, we are developing so-called vaccine Merah Putih, which is the inactivated platform vaccine, and also we are currently developing vaccine based on the adenovirus platform vaccine. Our expectation, this vaccine will be in clinical trial shortly in March next year. And then we also developed several robotics instrument and technologies for either for disinfecting, for helping the health professionals treating the patients, and also for providing services not only to the patient but also for the staff at the hospital. This is to ensure the security and the safety of the services during the treatment in the hospital particularly. And also we developed so-called the ARTA. It is assistance for triaging the patients in the hospital, whether this should be put it in the what is called severe one or mild one or minor one. So ARTA is helping the officer or the healthcare professionals to select which one should be prioritized. We also develop mechanical ventilator in order to resolve issues about the limited, in order to resolve issue about the lack of ventilator during the COVID-19 pandemic, and also some achievements in making like hand sanitizer or smart washing hand machine and digital apps which enable people to access information and also the closest healthcare facilities and any kind of educations which can help them to prevent from the COVID infection. These are our development, level of development at this moment. Some of the research and innovation are currently on research and development stage. There are some which already in trial and also some already implemented, like Marco, Kombipek is already used in several institutions or in the facilities or settings. Now, what is the next big thing? So there are some issues that we need to address, particularly during the pandemic and also after the pandemic. For example, we are currently trying to develop the smart hospital, which enable the providers and the professionals, the staff, the patients are accessing into same information system, which also can make the decision much more efficient. Cyber campus is already on its way. We are connecting the student, the staff in one virtual management system, and also artificial intelligence is another issue that we would like to achieve. However, it really depends on the on the capacity and the capability of our resources to handle the development of the AI. A number of big things that we would like to achieve within the next 5 or 10 years is the technology of robotic and biosecurity, particularly given that the pandemic is not only about SARS-CoV-2, but maybe there are other opportunities for another pandemic. That's why biosecurity should be our next concern as well. Immune system and genomic, as like Ben said, it is also part of the collaboration and partnership with the global universities and also institutions. This is why we would like to achieve more with respect to these two aspects. Telehealth and well-being are currently under operation and also tested whether it is feasible and can be sustainable for the future of the healthcare delivery. These are the next big thing that we would like to propose. And then again, it is part of the collaboration and partnership with other universities and also other institutions, either in Indonesia or in a global level. Thank you very much. These are our presentation for the 5 minutes. Thank you, Prof. David.
Thank you, Professor Andy. Professor Muljono, I believe you're muted.
Thank you very much. We proceed to the next speaker from Duke and US Medical School.
Thank you, Prof. Muljono. I'm Professor Ian Garron. I'm Vice Dean of Education from Duke and US Medical School. I can't speak to the COVID-related changes. I mean, it's not my area of expertise, but I can certainly comment on the school's response to the challenges in education, which have been significant. We've had, obviously, globally 18 months of continued disruption, and the main challenges that we've been experiencing more recently have been access to clinical training environments, which, for obvious reasons, have been somewhat curtailed because of all the safe distancing measures and all of the precautionary restrictions and requirements in place. I think the other challenge that we're beginning to see is a sort of impact on student and faculty well-being in general terms. I think there's been a significant emotional burden over the last 18 months, and we're beginning to see I think a form of COVID-related burnout. I mean, I don't know if it's got a specific characterization yet, but it does seem that the students and the faculty and just the constant challenges of just performing and acting and being normal quite significant. A few highlights. Obviously, the research side of the school has been doing a lot of work, and maybe Prof. Dale Fisher's probably better placed to describe the Singaporean national response, if that's possible in due course. But I think Singapore as a country has mounted a very impressive response to the sort of population health and the community health management of the COVID challenges. And I think Duke NUS has sort of played a key role, along with many partners across Singapore, to develop novel antigen testing capabilities. There's a neutralizing antibody test called the CPAS test, which has been approved by the FDA in the USA for testing of antigen or neutralizing antibodies, I understand. But there's also been the development of the Arcturus vaccine, which is, as I understand, in phase 3 clinical trials at the moment. So again, a lot of interesting work going on, a lot of very accomplished policy management and adaptation. And I think, and again, maybe Dale's got better detail on this. I mean, the total death rate in Singapore at the moment is still really only in the low 60s, I believe. So that's something of a miracle. I'm from the UK and we're losing hundreds of people a day still. So I think Singapore's general approach, both in terms of having a national centre for infectious diseases, which was very timely, opened just 2 years ago, has really made the national response quite staggeringly impressive, I have to say. So, as I say, educational challenges, the research side of the university's been really ramping up in terms of basic research. Linfa Wang and Prof. Ui Eng Yong have done great work with their teams, and also a lot of ancillary work around sort of T-cell mediated immunity and various other things by colleagues as well. So yeah, that's probably where I'll leave it. So lots of challenges on the educational side. I mean, I think we also will have to start considering COVID's now been with us for approaching 2 years, and certainly for a graduate entry medical school, that's half of their time with us. So we are also looking at monitoring very closely the performance and progression and development of our students, because they're not having what you would consider a normal medical education. It's not possible to give them that. So we're really working hard to support them, but also to make sure they're making satisfactory progression, both academically and professionally and clinically. So yeah, a few challenges, but many areas for commendation and for optimism going forward. So thank you. Back to you, Prof.
Thank you very much for your description and information. Now I would like to invite a presentation from Universitas Gadjah Mada.
Thank you very much, Prof. David. Let me share my screen. Can you see my screen, Prof. David?
Yes.
Okay,
yes, very clear.
Okay, first of all, let me introduce myself. My name is Gunadi, the principal investigator for genomic surveillance of SARS-CoV-2 from Yogyakarta and Central Java provinces. On behalf of Academic Health System Universitas Gadjah Mada, we present our experiences performing genomic surveillance of SARS-CoV-2. In this opportunity, I would like to present the topic of is the infection actually SARS-CoV-2 Delta variant associated with the outcome of COVID-19 patients. This is when the director of WHO classify Delta variant as a global health risk. And then this our Ministry of Health announced that Delta variant entered Indonesia on 3rd May. And finally, we found specifically in Kudus, Bangkalan, and Jakarta on 14 June. And interestingly, our country several times have been noted in Science and Nature news regarding the Delta variant surge on May, June, and July. This is the Nature Science when the Delta variant achieved its ultra-fast spread, including in Surabaya, Indonesia. Actually, the prognosis factor for COVID-19 outcome, there are several variables. The first, host genetic susceptibility, and then the second is host comorbidity, and of course the virus genome itself. And we have characterized around 161 genome from Yogyakarta and Central Java provinces. And interestingly, the CT value of Delta variant is lower than non-Delta variant. And also the age of patient have infected by Delta variant also much younger than non-Delta variant. The proportion of sex also different between Delta and non-Delta variant. And particularly the comorbidities of hypertension also different among two groups. And this is the phylogenetic tree of our samples. Then we can graph or trace where the Delta variant and Delta variant in our sample group with other genome sample from other countries. And while the pie chart and the below, left below, is the proportion of Delta variant, the blue one, and then the other is non-Delta variant. Next, we try to associate between the independent variables, including the Delta variant and also another prognosis factor, the outcome of patients with COVID-19. And interestingly, Delta variant does not have any impact on the outcome of our patients. However, the comorbidity, particularly of diabetes and hypertension, have impact on hospitalized the patient, and also the age of patient have a role on age of the patients. The patient outcome, and obesity, diabetes, and hypertension also have significant association with the mortality of the patient COVID-19 in our population. Next, we perform multivariate analysis again that Delta variant does not have any impact on COVID-19 outcome in our patient. However, the age of patients and comorbidity, particularly obesity, diabetes, and hypertension, have strong significant impact on COVID patient outcome in our patient. In conclusion, patients infected by SARS-CoV-2 Delta variant in our population have a lower CT value than patients infected by non-Delta. It's comparable with previously reported. But our data suggests the Delta variant might not affect the COVID-19 outcome in our patient. And older age and comorbidities increase the mortality rate of COVID-19 patient in our population. Further studies, of course, is necessary that the effect of Delta variant on vaccine effectiveness. Until now, Indonesia does not have any report about the effect of VOC, particularly Delta variant on vaccine effectiveness. And the second, of course, we have to look at the host genetic susceptibility itself, whether there are interaction or association with the COVID-19 outcomes. And the last not the least, we have to thank our team, big team from Academic Health System Universitas Gadjah Mada, but also another hospital that sent their sample into our institution, and also Balai Besar Veterinary Wates from Ministry of Agriculture. Thank you very much.
Thank you very much. Very comprehensive combination of clinical and basic science. Next, we would like to invite a presentation from National University of Singapore.
Okay, sorry.
Yes.
You can hear me all right, and I'm on full screen?
Yes, very clear.
Thanks. I was a little bit nervous when Ben started speaking, and I got the impression that this was all on genomics, because I don't have anything on genomics. So I'm glad the subsequent speakers were a bit more diversified. But I'm here representing Chong Yap Sang, our dean. So I thought he must have given me the wrong brief. Anyway, so I've just got a few slides on some of the efforts that are coming out of NUS, and yeah, perhaps towards the end, if you like, I'll take up Ian's offer and just talk a little bit about where Singapore's at. So in terms of some of the research we've been doing, 3D printing of nasopharyngeal swabs were developed. There's a clinical trial during our dormitory outbreak where we were able to recruit around 5,000 people, 5,000 male foreign workers who were in this sort of wave passing through these sort of highly dense foreign worker dormitories, so we could put them into 5 arms, including ivermectin and throat povidone iodine throat spray, and some got vitamin C, which we called placebo, and we found significant actually benefits in primary prevention using hydroxychloroquine and povidone iodine, and not so much ivermectin and other things that we would have thought. So we thought this was useful. It was naturally extremely unpopular, saying, sorry, we found a study where hydroxychloroquine might be useful, but and got a lot of flack from the reviewers for that. But nonetheless, that was a nice piece of clinical real world research. And then there's a lot of work being done on repurposing of drugs. Various departments across NUS are still on sort of early phase trials to look at potential treatments. In terms of diagnostics, we've got some rapid tests. These are 2 particular tests, which are so this is using nucleic acids. It's not using, apparently it's not PCR, but it's nonetheless, it's a rapid test. You can get it in result in about 30 minutes, and it's more than 90% sensitive. So that's patented, but not commercialized yet. And there's another valuable sort of rapid point of care test, which is based on a microfluidic chip. So way beyond what I understand, but nonetheless, this is another area that's been developed. Another group were developing an invention here where you could, particularly in areas where there may not be N95s or PAPR, and you've got to consider during aerosol generating procedures such as ventilation, this sort of box which could enable sort of a little bit more safety for healthcare workers, was another development. It's been a boon year for publications for all of us, I'm sure. Here's a couple of well-cited publications, but certainly many hundreds of publications through our university, and that's whether you're a surgeon or an obstetrician or a psychiatrist or an ethicist, and naturally it's been heyday for us infectious disease physicians. And I guess the last big effort I just wanted to talk about was in risk communications, community engagement. This is obviously and arguably the most important pillar of an outbreak response. So we picked this up very early. This is a cartoon series, which is up to about 160 cartoons now. So this last one is how we're just explaining how we're going to be gradually crossing the river into endemicity. And this is, for those of you in the know, is a sort of a Chinese proverb, how you can cross a river carefully, feeling the stones as you go. But by having these cartoons, they've been well distributed to tens of thousands of people in many countries. We also partnered with the Global Outbreak Alert Response Network, so they helped a lot in distribution, particularly those ones that made international sense. But this is a very, I guess, innovative and nimble way of being able to provide information. We can have a problem in the community today or a change of policy that might be confusing and get it out in cartoon form within 24 or 48 hours. So this was very useful. Some of you might be familiar with our webinar update series. We had our most recent one last night, 23rd. That was our 36th one. So through most of last year, we were doing these weekly, and yes, weekly, and it's very draining, but it's all about giving information. And these also attract tens of thousands of people. And again, partnering with GoOn to help the international audience. But we'll cover whether, why do you need to wear masks, through to what's up with the epidemiology and vaccinations and immunology and all sorts of things with my colleagues. So that was another thing. And on one of the sessions, we had a sort of a bumper crop, including we've had Tedros, we've had Mike Ryan, and Maria Van Kerkhoff and people from all corners of the world coming on as various guests. And the last piece of risk communications and community engagement was in the foreign worker dormitories, when we found that all these men were isolated, but with about 8 different languages involved, we really had no good way of communicating to people. So this was one dormitory that had about 25,000 men that were in isolation. So we could bring down and create various ambassadors, give them some materials that gradually built up to where you can see various materials and what's happening to you. Why are we swabbing all these people one day and the next day half my friends are being driven off in a bus? Are they being sent home, sort of? So will I still get my wage? They've got a completely different set of concerns and incredible mental health issues, being in isolation, unable to go to work. So anyway, we created lots of materials, developed Facebook pages with, this is a doctor from Bangladesh. This is one of the foreign workers. This is Tamwai Jia, who actually is in the Dean's office and had a calling and actually has this skill with cartoons. So I encouraged her along and got some WHO funding for her, and to create this group called My Brother SG, which is still alive and well now. Here she is actually working with the workers to get posters up and interacting, and now it's turned into this network of all these stakeholders which meets regularly to discuss how we can continue engagement even beyond COVID and into sort of longer term chronic problems that have been discovered, the diabetes, the hypertension that's been discovered during this outbreak in the men, as well as the essential sort of mental health issues. So that's really the 5-minute spiel from NUS. Singapore's currently I guess in about its 6th week of transition. We reached 80% double vaccinated of the total population, which was 90% of the eligible population of over 12s. We reached that point on August 29th. So, and really since a little before that, we've been talking about how we go through this passage, if you like, and in the last month we've gone from just over 100 cases to yesterday was 1,500 cases, and the pressure on beds is starting to increase, and the question over whether we need to reimpose restrictions, which all we actually did was allow dining to resume in restaurants and hawker stalls. We've still got universal mask wearing indoor and out. We've still got limitations of numbers mixing, which is maximum of 5, except in special situations such as weddings and funerals and conferences, which are closely managed by other mechanisms. But we haven't done much. And I don't know what happens if for countries that do Freedom Day, their hospitals must be having hell. We're finding half the cases are the unvaccinated, and half the cases that need hospitalization are still the frail vaccinated, but you can see the value of the vaccine as it's still kind of 50-50, even though there's 10 times as many vaccinated as unvaccinated. So I guess Australia's watching closely as they get to those sort of numbers, and they're going to have a lot more pressure, I think, to open up, whereas Singapore's quite a bit more conservative, I think, and is happy to see how things go. And in fact, a lot of the community's calling for more lockdowns. So we're saying no, we have to run this gauntlet. We have to get to the other side and have endemicity and get back to normal. So there's 5 minutes on NUS and 2 or 3 minutes on Singapore. Thanks.
Thank you very much, Dr. Dale Fisher. We still have 6 or 5 speakers from now. With a limited time, I would invite a representation from Universitas Indonesia.
Good morning, Prof, Doctor, ladies and gentlemen. Thank you, Prof. David, as moderator for this opportunity. Allow me to introduce myself. I'm Vera Ibrahim from Department of Microbiology, present with Linda from the WJS team, Faculty of Medicine, Universitas Indonesia. In fact, Universitas Indonesia also developed various research with different aspects to manage COVID-19 pandemic. But in this occasion, we just report our WJS activity. Let me share my screen. As we know that the problem of the SARS-CoV variant has developed a concern for all of us. WHO has made the classification because it has an impact on health. We know that the virus constantly changes the mutation, so the new variant will be emerge. It could be disappeared or persist. It's dependent that variant of virus could adapt it. The potential consequence of the emerging variant is the ability to transmission, severity, and disease, and also a problem in the diagnosis test or the therapeutic agent, or also efficacy of the vaccine. Of course, the WJS surveillance is important for monitoring evaluation of a new variant virus. To do the WJS surveillance, Indonesia formed a consortium that conduct a WJS survey. This consortium led by the NIHRD Minister of Health and Eijkman Institute Minister of Research and Technology and BRIN. With the objective of molecular epidemiology, tracking sudden increase of COVID-19 case for disease management, and coordination at the national global survey. The consortium consists of various research institutes, university, and other laboratories, both private and public sector. Initially, funding by provided by each institution. So then the government, through a decree from the Minister of Health, appointed 21 laboratories as the WJS surveillance lab network, including our laboratory at the Universitas Indonesia, also with UNER, UGM, and Syarif Hidayatullah Islamic University. Lab network has been supported of reagent to carry out the WJS, and then we assign to do the WJS for certain locations, such as we have assigned to area Kalimantan and West Sumatra. You can see here that the formation of the consortium gives an impact. There are an increase the ability or the capability of this WJS and coverage with almost all part of Indonesia, although the number is not sufficient and not evenly distributed. Our laboratory WJS surveillance at the Medical Faculty of Indonesia, we try to establish at the early 2020, and after we have several meeting and preparation, so in fact we can start to work in the July 2021. Of course, we have already the facility to do the WJS, and we do the WJS at the Clinical Microbiology Laboratory and Emery Bioinformatics Laboratory with the funding from the Universitas Indonesia, PT Nutrisia, and ISRD for the reagent and some research grant. Of course, the challenge is sustainability of fund and also the procurement of reagents that takes time. Our case target is international traveler or migrant worker, people from the border area And also, if there are an increased case in some area and people who participate in the vaccine trial or have been vaccinated completely, but we can find that positive. People from the history of infection and reinfection, people with the autoimmune, and children, and also the people who have a seriously ill if the age is less than 60. This is our WJS lab journey. In fact, we have started at the March with the funding from some research grant, and we established the laboratory at the FMUI at the July 2020. So we can see here per September 17, 2020, we have already submitted 92 FGC and 95 still analyzed. So we analyze about the cluster positive case post vaccination and also a case that related to security disease. And also we monitoring and circulate variant rate. This is our report to the research. There are 92 samples, and then we have about the 30% Delta variant, and we have one Beta variant that from the traveler from Bosnia, and other consists of strain B1 and variant. So we report our WJS activity. There are several reports that also we report that we can find obtain the T-cell epitope-based vaccine analysis, and also we report about analysis different kits to improve and optimize WJS implementation. I think that's all our activity for the WJS in the Faculty of Medicine FKU, University of Indonesia. That's all, Prof. David. Thank you.
Thank you very much, Dr. Vera Ibrahim. Now we proceed to the next speaker. I invite a presentation from University of Malaya.
Thank you very much. Are you able to hear me all right?
Yes, very clear. Thank you.
Okay. I just have a short presentation. And firstly, I would say that I echo what many of the previous speakers have said in terms of the challenges that we face as an academic health center. I'm from University Malaya. We are based in Kuala Lumpur. And we are actually seated right in the middle of maybe the epicenter of the COVID-19 situation in Malaysia. So we're within the Greater Klang Valley, and that accounts for more than half of the cases currently in the country. But what I thought I would do is just share with you how we have actually translated some of our research activities into a meaningful and impactful change in terms of COVID control. So last year, Malaysia had actually gotten to a situation where we were in terms of single digits for new cases every day. And, everyone thought that we're out of the woods and we'd be back to normality. However, towards the latter half of the year, we saw a number of clusters that developed. And because Malaysia has this all-of-country response to COVID-19, the research clinical response is actually coordinated by the National Security Council. And so our university was involved in identifying the lineage of these clusters. And this was a paper that some of my colleagues worked on. And you can see that these were mainly B6 lineage. And why this is important is that if you look at today's situation, you will see the numbers are very, very different. We're no longer talking about single digit or even double digits. We're looking at 5 digits in terms of new cases. And what we have found is that the new variants are now accounting for the vast majority of cases. And that has impacted the healthcare community's capacity to respond. So we actually anticipated that this was going to happen thanks to a very strong public health department, as well as our infectious diseases team. And so early on, we decided to develop an app which would allow us to monitor category 1 and 2 patients at home so that we could actually reserve our hospital resources for those that really needed to be in-house. And so this is our Cosmos system. This was developed in-house by our primary care team. And this is now being utilized not just by our hospital, but also by other sectors, and it really allows us to monitor patients closely while they remain isolated at home. Secondly, we identified that while the vaccine rollout in the country began early this year, there was quite a lot of, number one, vaccine hesitancy, but there was also difficulty in terms of accessing the vaccine centers. And so our university hospital decided to collaborate with MRT Corp. This is a private transport company, as well as Prasarana, which is the government sort of transport arm, because we recognize that it may be not so much that they don't want to be vaccinated, but they can't actually get to the centers. So we collaborated with these 2 companies, and as you can see, we've conducted a number of outreach immunization programs targeting really the underserved areas, villages, and you can see that we have actually managed to vaccinate a large number of residents. So what has this meant for us? I just wanted to direct your attention to the graph on the right. This was at the beginning of August, and you remember we had started vaccinating the program of outreach vaccination slightly before that. And what you will see now is that our number of new admissions has dropped significantly. And in terms of those that are actually within the COVID ward, you will also see that that's dropped significantly. So I think this is really meaningful change that we have managed to effect within at least our catchment area. And I think this is being taken as an example for the rest of the country to follow. Just last slide here. We're not just about research and clinical service delivery. We also have to focus on our programs, our educational programs. And while many of our other sister universities have sort of taken an all or nothing approach, so that when we had the lockdown, they basically stopped all in-house activities. At University Malaya, we have decided to use the scientific evidence, and we have had a very tailored approach. And so firstly, we made sure that all our clinical students were vaccinated. We followed that very closely with our non-clinical students who were dealing with tissues or were otherwise engaged in the front line. And that has meant that we have been able to always have a hybrid sort of delivery. So our clinical students are actually in-house. They are actually having bedside teaching, but of course, following very, very closely the necessary standard operating procedures. And so we've managed to actually stay on track in terms of graduating them, at least more so than other universities in the country. So thank you very much.
Thank you very much, Dr. Aprilia. We still have 3 speakers and we are running out of time. I would invite a presentation from North Sumatra University. Would you please make it short because we only have time until 10:30.
Okay, thank you very much, Prof. David. So my name is Muhammad Ikhwan. I am working as assistant to the dean in research collaboration and community service. So I'm speaking here on behalf of the Dean and also the Chief of the team for WGS research in University of North Sumatra, Prof. Aldi and also Dr. Inke Lubis. So dear all colleagues and also the members and also all the participants, please let me share the screen to show about a little bit about what we have done in University of North Sumatra. So this is the current situation in North Sumatra, that we had quite a significant surge in the cases in the beginning of July. And then now, luckily, we already start to have a decline. And also the recovery of the patients start to increase. And hopefully we will have a stable conditions in this current days or weeks. And USU itself, we have two main teaching hospitals, namely University of North Sumatra Hospitals and also Adam Malik General Hospitals. And both of these hospitals are referral hospitals for COVID-19 patients. And in North Sumatra, we have a COVID-19 task force and staffs, and also University of Sumatra Utara. We are closely engaged in this task force to do all the policy and also implementations of the policy in North Sumatra. Especially, for instance, like isolation center and also COVID-19 emergency hospitals. USU is engaged in this program. Faculty of Medicine of University of Sumatera Utara, we have PCR tests run by Laboratory of Microbiology in Faculty of Medicine. So start from the beginning of the pandemic until currently, we have already analyzed around 130,000 samples. And this is the conditions from the all record database. So start from the launching of this database, we already have analyzed around 10,000 of specimens. Routinely, for all the students, co-assistants and residents and also staffs, we perform a routine PCR tests by a Laboratory of Microbiology. And this is for the example that we perform from January until September. Here we see also from the rest among the residents, we also have a slightly increase of positivity in COVID-19 in July. And then it's now start to decrease again. The PCR labs of Faculty of Medicine also train and supervise another laboratory in North Sumatra. Start from 2020 until now, we also help the other laboratory to establish. And also the vaccination programs to healthcare, lecturers, students, all residents, and also for the all the society, including elderly, pregnant women, and also high school students, especially the high school students, to prepare for the offline learning course. And USU also launched currently telemedicine for to help the patients with mild or moderate COVID-19. So they will get free consultation, so they, and also another basic toolkit medications, and also to provide them consultations and also suggestion during their private isolation. And also we produce hand sanitizers and to be distributed to all the buildings at the University of Sumatera Utara, and also to all the staffs and students, those are need these sanitizers. And also alumni and also another society in USU also launched the CARE program. So they will provide personal protection equipments, especially in the beginning of the pandemic, which were very expensive. So we tried to we distributed this for free for lecturer and staffs, and also especially for residents and medical staffs and co-assistants. Education and guidelines, we provide that in the form of the videos posted in YouTube, and also guidelines for the offline learning preparations, COVID-19 in children guidelines, and also some medical seminars for medical staffs, for doctors, and also for public. So we have a lot of webinar series. And in terms of the whole genome sequencing project, we also have collaboration with Airlangga University, Eichmann Institute, and GISA Lab, where we already sent 24 samples to Airlangga, 165 samples to Eichmann, and 50 samples to GSI. Those samples are obtained from the samples from microbiology lab of Faculty of Medicine USU, USU Hospital, Murni Teguh Memorial Hospital, Columbia Asia Hospital, and also Komang Makes Navy Hospital. And then from the samples, those are collected from 14 till 30 July 2021. We obtained 48 cases. Those are positive for this particular variants or lineage. Thank you very much. This is the hopefully can give brief insight about USU, and we are very happy to be joining this collaboration, and we are looking forward for further discussion. Thank you very much, Prof.
Thank you very much, Dr. Ikhwan. Now we proceed to the presentation from UIN, Sharif Hidayatullah. Please, UIN.
Okay, thank you for the opportunity. I'm Fika on behalf of my dean here. Actually, my dean here, Dr. Hari, has already also joined this meeting, and I want to I want to tell you that we are new here in the AAHCI since Prof. Ari asked to join this respectable meeting, and we are glad to join here because we are a new university. So not university, new medical faculty. So I want to explain about our activities related to COVID-19. Maybe it's not as great as the other university that already already established compared to UIN University, because medical faculty, because we are still about 15 years after we established. So this is our activities related to the COVID-19. Maybe we want to explain about the supporting laboratory. We are now as supporting laboratory for Banten province since June 2020 until now. And then we are trying to developing genomic analysis from the samples we received after, since then. And we have already joined WGS, WGS, in Indonesia. And we have the old one, and until now we haven't update the WGS from OIN, but we have submitted 11 samples from our side. And then we also did the study in side effect after vaccination from UIN site vaccination. So we have done many times for vaccination as a vaccination site for students or other community surrounding the UIN, and also in the hospitals and students. And we did the study for side effects after vaccination. And then the third one, we are in progress as site for phase 3 clinical trial COVID-19 vaccination. As other universities here, as such as UI, UNPAD, and other sites, maybe also, if I'm not mistaken, the I don't know whether USU also joined this clinical trial phase 3. And then the last one, because before our leader here, the AAHCI mentioned about the public health, we also have the we have done the fostering pesantren. We have the special community related to boarding education, especially what is it? Related to the religion, for Islamic religion. And then we have fostering this through the public health, especially for the health promotion. And for the progress study for the WGS, we have mostly strain D614G, and the sample mostly from Banten surrounding. And actually, since recently June until from May to September, we have done some study also to see the variant of the COVID, and from the 65 adult patients with COVID-19 positive, we have 63 patients with Delta variant, but only 2 patients with non-Delta, but it haven't submitted to WGS. And this is the description about what we have submitted to WGS. And I think that's all for our presentation, because we are still developing and we want to learn more about this collaboration to UI and other university from our country, and also from NUS and other. It's a great opportunity to have this collaboration. We want to have what is it? We want to dig and also have more integration program with this collaboration. Thank you.
Thank you very much for the informative presentation. Now I would like to hear and invite presentation from the University of the Philippines.
Yes, good morning. Allow me to share screen. Seem to find.
Do you want me to share?
Here.
Really?
Here.
Okay.
Hindi ko lang mahanap.
Okay.
Can you see it na?
Not yet.
Yeah, it's coming on,
It's coming.
but not yet there. Yeah.
It's here in my screen. Wait, I'll redo the.
It might be the connection. Dean Charlotte, if you want to try, it may be.
You want me to try, Coralie?
Sige, you can try.
Is that showing?
No, I see it on my screen, but I can't move it. It looks like it's locked.
Yeah. Can you see my screen now?
Yes, we can see it.
Yeah.
We can see from your screen from our side.
Yeah, so maybe I can just do this, Coralie.
Okay.
Because I can share it from my screen. So thank you for the opportunity to share with you how COVID-19 has impacted training and education, and these are the challenges and perspectives from the University of the Philippines College of Medicine, which is in the University of the Philippines, Manila. Basically, as you know, our College of Medicine is about 115 years old, and we have 3 academic programs, the 7-year program, the 8-year program for our MD PhD, and also the traditional program, which is 5 years. We follow the organ system integration, and we have now an increasing number of graduate students among around 26 graduate programs. We're intimately connected with the Philippine General Hospital, which is really the largest training hospital in the country. It's about 110 years old, and we have about 600,000 patients being seen here. Pre-COVID, we have about 575 residents and about 311 fellows in training. So clearly, the COVID-19 has impacted us similar to what has happened in World War II. Although we did not close both the college and the hospital in World War II, we were able to graduate medical students even at that time. The impact of COVID in terms of mortality in our country is staggering. And so that's what I would like to share with you. So this is the slide showing the incidence of the prevalence of COVID at the time, July 11, 2021. You can see here that the total number of cases was 1.4 million, and the total number of deaths was about 25,921 or 26,000 if you round it up. And just over a period of 12 weeks from that time, we are now counting more than 1 million cases, increase in the number of cases. And there have been an increase in 12,000 deaths over those 12 weeks. So it's an increase of about 1,000 deaths per week that we're talking about. And we clearly would say that this is probably being driven by the new variants of concern. These are the stats as of July. And we now have an increasing number, as you can see here, starting around August 1. It's been increasing, and right now we're in the middle of a really big surge of COVID-19, probably driven by the different variants. As of August, we did a surveillance, and at that time, so basically, we were looking at the Genome Center biosurveillance report here, and we see here that % were actually about 20% from the Alpha variant or the UK variant. And Delta variant is actually comprises at that time only around 7% of the cases. But this is continually being under surveillance, and probably in the next week or so, we should be able to get new data regarding this. You can see here that in terms of the demographic profile of how COVID-19 has impacted our population, you can see here that, of course, all ages are affected, but the number of deaths are actually increasing above the age of around 60 years old. Not so many for the younger population, but in fact, the most affected are those in the 20 to around 39-year-old age group. We can see here that in terms of challenges to medical education in our college, we basically, what you term, we dance with the virus. We suspended the classes initially in March, and then we provided learning opportunities by remote to our students. by the time that around September, they were requiring a reading break. They were so affected by the remote learning. Our faculty had to do a lot of shifting in terms of being able to deliver the courses. And at about around March of this year, we started COVID-19 vaccination. And right now, we're talking about more than 90% vaccination among all our students. So that has helped us try to basically meet the challenges of education. So as like all of you, we had to shift to remote learning. Of course, there are several things that had to give way. For example, we had to shorten the curriculum, the course duration, and therefore we had to make adjustments regarding that. And depression among our students. We had to look at innovations in teaching and learning. And basically, our faculty have conflicting demands because of most of them are frontline healthcare workers in our hospital. So we had to really balance service, teaching, and research. There's been an increased discussion regarding the grading system, whether it should be a numerical or a categorical pass or fail. We had to increase our number of staff in order set up an educational technology unit. Our students had to be volunteer in the Bayanihan call center, which is actually a public outreach in order to help the public deal with COVID. We had to also volunteer for vaccination programs in the government. And since there was no dissection for the whole first year proper students, they clamored for virtual learning, which we provided by getting all these digital anatomy tables, and also some prospect of face-to-face summer classes for anatomy. So main problems still revolve around integrity of assessment and feedback, as well as our psychosocial concerns, as I mentioned, because about 50% of our students now report anxiety and depression. So these are some of the solutions that we did for Zoom fatigue. We actually looked for alternate activities. We also conducted a lot of trainings for our faculty, who at that time only had 11% of our courses before the pandemic and had to be shifted to about 100%. And our country has poor connectivity and very expensive. So we had to give mobile loads to our students and some of our admin staff in order to help them with the cost of internet connectivity. We, of course, a premium for PPE wearing, vaccination among our staff, admin, and our students, which we facilitated. And for our hospitals, about more than 70%, now I think it's about probably 90% of our PGH employee population have been vaccinated. And we had to, this is a century-old hospital, so we had to do a lot of safety engineering controls and zoning, as well as being able to have the Bayanihan COVID area zones to be always in the mindset of our employees. And by that, we also have a daily roundup of the number of cases in the hospital and admissions to be able to, and as well as alerts from our hospital infection control unit, so that we can disseminate information. We are basically adapted to change. There's been no time in history where we had too many researchers actually, and more funding from government. I think at this time we have about $500 million for research, and the 298 is now up to about 500 researchers now. Mostly we are the site for the WHO Solidarity Trials for therapeutics as well as vaccines. And we have a lot of innovation, especially in the first 3 months after the lockdown. We had telerobots, we had the sanipods, sanitation pods, we had RX box monitoring for fetal and maternal monitoring that became telemetry stations for our hospital. And this has been very important in being able to ensure safety in the hospital as well, and improve the wellness of our employees. We continue to build an iconic building solely built on philanthropy, the Henry C. Senior Medical Sciences Building, which will have one of the biggest clinical simulation center in our country, and we've been able to get Congress to fund this. And there's been an increasing number of cases in the now as we speak. of the pre-COVID statistics, and we also continue to have more services now available in our hospital, like newborn hearing screening and audiologic services in our own unit in the hospital. And we were successful in having around about 157 students come to the college for their bridging classes in anatomy. And we were able to do this while complying with the regulations of the interagency task force of our government for safe face-to-face classes for our preclinical years, and prospected all this so that they could stay with us for about a week up to 2 weeks, depending on that batch, because Delta variant came. So I think that's about it. We still grapple with the increasing number of cases, but the vaccination here in the Philippines is quite slow, but we've been able to manage by having our health prioritized and also our students so that they can come back for face-to-face. So as we speak, our interns are the last year of their medical school. They are now back, and we're hoping to get back also the clinical clerks soon in order to improve their experiential learning. Thank you very much.
Thank you very much, Dr. Chong. So we have finished listening to the presentations of the 9 speakers. Actually, we have passed the schedule, and I have asked the committee for extension for our discussion. This is an excellent session that we have a wide spectrum of presentations, from basic science to applied, including prevention, treatment, and to the public. I would like to invite everybody to discuss or to give comments, but I think please make it short and try to summarize. And I think it's better for me to request Professor Howden first. Maybe you have comments.
Thank you. Thank you for the offer to comment. You know, I think it was a great range of talks, and as you mentioned, covered a whole range of topics. I guess my first comment is that, you know, we're seeing consistent issues and responses around our regions, and, you know, it echoes what we're doing in Australia. So all of these, hearing all of these responses, and the scientific and public public health responses are you know, echoed around all of us, and we're all dealing with similar issues, from how to use genomic technology and integrate data and make it useful for public health responses and make sure we detect variants of concern, through to dealing with students and their learning experience and those sort of things. And so I think, you know, we're all in this together, and you know, I can really see that sense of echoing similar themes across all of the talks. Just to go back to my topic of genomics, you know, it was great to hear some of the presentations on the genomic data that's been generated and the importance of that data, but also a lot of discussions around how to make this more powerful. And I think that gets back to that idea of, you know, making sure we're selecting the right samples to sequence, trying to do it as efficiently as possible, and then working out how to integrate that data or share it and analyze and report it in a way that we can get a summary of that data that's useful for informing our understanding of the evolving pandemic and also the response to it. So these are things that are going to take a long time, but it's great to hear those discussions happening across multiple sites. So thank you very much. That's all I'll say.
Thank you very much. Is there any more questions? If I can ask, we can finish it at 11 o'clock. Maybe. You can ask to other members or other centers, or maybe initiating collaborations and coordination. Yeah. Prof. Ari, maybe you have comments.
Yeah, thank you, Prof. David. I think if there's no question, we can close the session.
Thank you very much. So my last comment or suggestion is that we have an excellent collaboration, and if I'm allowed to propose that it needs to be followed with collaboration, because we belong to the Southern Hemisphere, and according to the SDG and also the UNDP, there should be a South-to-South collaboration led by your host. And I hope that will be continued with other activities regarding the broad spectrums of activities in this region. Thank you very much. Have a good time, and also have a weekend tomorrow, and stay healthy and safe. Thank you.
Thank you. Bye, everybody.
Thank you.
Okay. Thank you for all members of AAHCI Southeast Asia region for spending your previous time for today's discussion. Thank you.
Thank you very much.
Thank you.
Bye-bye. Thank you.
Bye.